Hello everyone, we're going over inflammatory bowel disease today. So today we're just doing a not what I would say is a comprehensive review, but a key point review. So this isn't going to cover everything that you may see on these two diseases, but I think these are the high points and the high yield things that you're going to find when trying to differentiate whether it's it's IBD from the question stem, right? But you don't know if it's ulcerative colitis or Crohn's disease, and that's where we're coming in and trying to figure this out. As always, if you like the videos, check out my other ones. Don't forget to like, comment, and subscribe if you do like all the channel's videos, and we will be putting out some more videos for clinical med, anatomy, physiology, etc. Let's get started. IBD, it's a massive inflammatory state, pro-inflammatory state of the colon. And this pro-inflammatory state is mostly mediated and brought out by innate cells in the colon that will produce massive levels of TNF alpha, interleukin 1 beta, 6, 13, and 23. So these are all pro-inflammatory cytokines that are going to come out, and this is often because of either a bacterial state in a normal human like system. You may have a like C. diff infection, and these mass, not quite massive, but normal amount of innate immunity will actually produce these in a normal state. However, in inflammatory bowel disease, these are just produced 24/7, and the inflammation never really goes away. It just continues on and on. And because of that, you're going to get a massive number and a high number of these Th17 cells that are going to be found in the inflamed portions of the colon or of the bowels in and of itself. And IBD is often differentiated into either ulcerative colitis or Crohn's disease. How do we diagnose it? We usually diagnose this via endoscopy or colonoscopy. So scoping either which way you want to go about it. Most often, you can also use imaging like MRI, X-ray, abdominal CT. And as always, just as an aside, if it is a patient who you suspect could possibly be pregnant, always make sure before you do an abdominal CT to get a negative pregnancy test, because it is contraindicated in those that are pregnant. Um, and that's just an aside. It's like really stressed in medical school. Like every exam that has anything involved with abdominal CTs, that's a huge thing. Also, you can use stool samples to rule out infection, because sometimes these pro-inflammatory states may not be IBD, may just be an infection for like example EHAC E. coli, enterohemorrhagic E. coli, or you can want to use those fecal occult stool samples to actually find or even rule out possible colorectal cancer that may arise from IBD. Because remember, IBD is a pro-inflammatory state, and what do we know that cancer likes? It loves inflammation, so it is a common risk factor for it. Ulcerative colitis, while these are not common, I'm just saying that it is a risk factor for it that is commonly found in these patients. So ulcerative colitis, we'll go ahead and start with that one first. Key features that distinguish it. Ulcerative colitis will only have mucosal and submucosal ulcers. So I have this convenient handy dandy graph right here, figure right here, and you can actually see the mucosa and the submucosa right here. It's not going to involve any of the thick muscle layers that you'll see of the smooth muscle of the small bowel or small intestine or the large intestine. It's not going to involve the subserosa, and it's not going to fall into the serosa. So you're only really getting these top two portions in ulcerative colitis. It almost always involves the rectum. Crohn's disease is rectal sparing, so this is a big one. So if it's involving the rectum, you know it's probably ulcerative colitis. If the rectum is spared, it is possibly Crohn's disease. Also, if you see down here, this is pseudo polyps. So these look like polyps, but they're not. They're the pro-inflammatory state that the colon is actually experiencing. If you see that on gross imaging, this would actually appear in ulcerative colitis. So ulcerative colitis appears with those mucosal pseudopolyps. Continuous colonic lesions that always involve the rectum, again, always involve the rectum. These continuous lesions are often found in ulcerative colitis, as well as left lower quadrant pain. So left lower quadrant pain. LLQ is probably the abbreviation that you may see on a vignette. Contrast this with Crohn's disease that has right upper quadrant pain. Smoking, this has always been a little counterintuitive to me, but smoking is actually protective against ulcerative colitis, but it is a causative agent for causative risk factor for Crohn's disease. Ulcerative colitis can lead to toxic megacolon, which is the inflammatory state. It's all about inflammation in this one. It's a pro-inflammatory state in the giant colon that is brought about by a infection. Most often it's C. diff, and it always causes bloody diarrhea. Ulcerative colitis always causes bloody diarrhea. Crohn's disease, however, sometimes causes normal diarrhea and sometimes bloody diarrhea. So here's a picture of a normal colon. You can actually see the haustra, and this looks like a normal pouching, nice pouching of the colon, and you can see that it's that slight tinge of beige red. I don't know how else to describe it, but it looks like a normal colon, right? And then you look right here, there is a massive inflammation of this colon. You can see the redness, the swelling around the colon. It's almost to the point where you're not really seeing through the colon in and of itself. So this is from a colonoscopy. Also, because you are losing these haustra, so those contractions of the colon where you actually get that characteristic large colon pouches, you're going to have this lead pipe sign on imaging. So this is an abdominal X-ray, and you can actually see this is the descending colon down into the rectum. So there is a giant lead pipe on imaging that is pretty much dead on indicative of ulcerative colitis. Crohn's disease, it can occur anywhere in the colon and in the small bowel as well. It can also involve the small intestines, excuse me, but it most often will involve the terminal ileum, the ileocecal valve, and the cecum. It has skip lesions, which you can actually see here. So you've got a portion that's afflicted here, the ileocecal and terminal ileum, and then into the small intestines here. It also has what we call creeping fat. So it's going to have these extensive mesenteric adipose tissue, basically fat that just extends over the inflamed region. And that's actually seen right here. So this is your usual mesentery with the mesenteric fat. And that's going to kind of creep up over these areas of inflamed intestines. And so you can actually see another one of these right here. But I actually like this image a lot more because it actually shows you kind of the creeping factor that kind of goes through this. And so again, Crohn's disease, skip lesions, it'll skip areas of healthy colon and then inflicted colon and then healthy afflicted. With, ulcerative colitis, you're going to have continuous colonic involvement and continuous ulceration of the colon, almost always beginning in the rectum and going upwards into the descending colon. Key points, again, from where Crohn's disease will differ from ulcerative colitis. Remember again, ulcerative colitis almost always with the rectum is almost always going to contribute to the rectum having a pro-inflammatory state. Crohn's disease is rectal sparing. It is associated with mutations in the node2 gene. So Crohn's disease, if you see anything about the node2 gene being having loss of function mutations, this is a dead center for Crohn's disease, but often they're not going to make it that easy on you, so they're going to ask you what is going on with Node2. So Node2, remember that this encodes for the PRP that recognizes that for bacterial LPSs, and it'll activate the NF-kappa beta pathway. And this is what's going to cause the impairment of the innate immune system, and you're going to get just this haywiring of inflammation in the intestinal mucosa, which then leads to Crohn's disease. Also, on imaging, while you saw the lead pipe in ulcerative colitis, for Crohn's disease, you're gonna get this kind of string sign, and so that's indicative of Crohn's disease on imaging. Also, you're going to get these knife-like fissures that are seen in Crohn's disease. So it almost looks like someone took a knife or a scalpel and just started making like these fissures through the bowel. And you're going to get right upper quadrant pain. Remember that ulcerative colitis had left lower quadrant pain, while Crohn's disease has right upper quadrant pain. So you can often assume that, if a patient's coming in and complaining of right upper quadrant pain, what's going to be first on your differential, right? You're going to think, okay, this may be a gallbladder issue, this may be a liver issue, but now we're going to think about, okay, maybe they're having a Crohn's disease flare up, right? So this is just another thing to put on your differential here. And it also appears grossly with this cobblestone-like mucosa, which obviously should not be inside of the lumen of the um, bowels, but it is. So these little kind of cobblestone, I would almost say it's like a cobblestone road. That's kind of how I see it. If you've ever been to Europe and you see those cobblestone roads, that should immediately make you think of Crohn's disease. Sorry to ruin cobblestone roads for you, but that's just how I think about it. Complications from Crohn's disease, you'll get gallstones or gallstones that are due to the terminal ileum involvement. And remember that the terminal ileum is really important for a lot of things, namely, and the reason why it's causing gallstones here is that the terminal ileum is where the bile salts are normally reabsorbed. So those bile salts are taken into the lumen, and we're going to absorb our fat and our vitamin A, D, E, and K, those fat soluble vitamins. So not only are you getting gallstones because your bile salts are not absorbed, you're getting malabsorption of that, you're getting fatty acid malabsorption, and you're also getting vitamin A, D, E, and K malabsorption as well. So this can cause a list of complications, which we're not going to really go over yet, but just know fatty acids malabsorption because the terminal ileum has most often involvement with Crohn's disease. You're also going to get calcium oxalate stones because that increased intestinal fat that's inside of there that we're not uptaking, that's going to bind more calcium, and more calcium ions are less calcium ions are going to be available to bind oxalate, and this ends up increasing our oxalate absorption, which then comes into the kidneys, deposits, and starts to make those oxalate stones, which again are a form of kidney stones. Also, with either ulcerative colitis or Crohn's disease, you're going to get colorectal cancer, an increased risk for colorectal cancer in the future. Smoking also increases the risk for Crohn's disease, which again, counterintuitive, but for ulcerative colitis, smoking is protective against it. Again, you're also going to get pernicious anemia, megaloblastic anemia, due to that terminal ileum damage. All right, guys, that is the quick and easy kind of guide to ulcerative colitis and Crohn's disease. Again, if you liked it, go ahead and like the video, comment down below, and subscribe if you like the other videos. And thanks for watching, guys.